Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Welcome back to another episode of Unraveled Understanding Complex Illness. I am Dr. Eileen Ruhoy. I'm with my BFF.
David Kaufman, hi.
And we are going to have a conversation today about small fiber neuropathy. And I know that we've sort of touched upon it in various other episodes in the past because you cannot talk about chronic and complex illness without at least mentioning small fiber neuropathy. But we're going to sort of talk about it, as a topic of its own.
Yeah, it's a big topic and very challenging, as we both know, and certainly our patients know even better.
Yes.
And it's interesting. Small fiber neuropathy, for me, way predates my work in ME/CFS, long COVID, and all of this stuff. I mean, that was a huge issue in the HIV days, and equally challenging and equally frustrating. And the poor patients really have pain that we struggle to cope with.
I do remember reading about small fiber neuropathy and HIV. It is a very prominent diagnosis.
Right.
And also, sometimes they refer to it as a sensory ganglionopathy because there was a lot of facial involvement where a lot of the pain complaints came from the facial distribution.
It's interesting, though. I mean, we'll get into this in a minute, but so we'll come back to what I'm about to say. In our patients now, in general, I'd be interested to see what you say, but in general, I think small fiber neuropathy is intimately associated with the dysautonomia and POTS.
Oh, 100%.
But that wasn't true in the HIV days.
Well, I think it just wasn't.
It was a different etiology, different cause.
But also, so they didn't have autonomic
Well, they
concerns?
didn't have POTS. I mean...
But what about all the other autonomic symptoms that I see regularly in my small fiber neuropathy patients, right?
But nothing like our patients.
Okay.
At least that
That's
I recall.
interesting to
It's
me.
a while back, but I don't remember having to do or deal with a lot of the autonomic dysfunction that now is literally 24/7.
Yeah, but now with our patients, it's not only just obviously the neuropathy part, which we'll talk about, but because of the autonomic fiber involvement, there's usually some alteration of sweat function, whether it's increased, decreased, or absent, and then a lot of postprandial nausea and bloating, constipation, dry eyes, dry mouth, erectile dysfunction, urinary retention. So none of that was in the HIV population.
So I don't remember having to take care of that stuff at all. Now, it may be that the patients were so sick with their opportunistic infections that some of the postprandial stuff got lost in the noise, in the shuffle. You know what I mean?
Yeah.
But I definitely...
But that should be the focus of study then, don't you think?
I know. It makes me want to go home and look it up again.
Right.
So I just don't remember having to do that work.
Because there's a unique and I didn't do HIV like you did, but there is a unique T cell response to HIV, right?
Right.
And so I wonder if there is some mechanism by the immune response to HIV versus the immune response to what we see today in chronic and complex illness that would...
I'm sorry. Go ahead.
No, that would exclude the autonomic fibers.
Yeah, I think it just is a different cause. It may have been a direct viral injury to those nerves as opposed to autonomic, the way we think of it, where small fiber is part of the whole autonomic dysfunction.
Right.
It's almost like, I tend to think of small fiber neuropathy as sort of a surrogate marker as further confirmation of the overall dysautonomia our patients experience.
Right. It certainly is. And obviously on autonomic testing, you do the QSART, the quantitative pseudomotor reflex axon test, which is a marker of sweat function, which is also correlated to small fiber neuropathy.
Right.
And I have yet to see a QSART that was abnormal without a skin biopsy being abnormal. So there's definitely a real correlation. It's so basic. Small fiber neuropathy, it's the small unmyelinated and the thinly myelinated fibers of our peripheral nervous system. They're sort of diffusely distributed. A very common presentation is length dependent, interestingly enough, which means that it starts in the feet, it ascends up the legs. Usually when it gets to around the knees, you start feeling it in your hands and it ascends up your arms. But there are very often a non-length dependent presentation, which is just sort of multifocal and patchy and can be anywhere and can have the face involvement as well. So it's not always length dependent, but it very commonly is, it seems. And so, it's the alpha, delta, and C fibers and very much associated with autonomic dysfunction, as we talked about. But usually the neuropathy portion of it is either numbness or tingling. I get a lot of people saying that they feel crawling sensations.
Right. Like bugs under their skin.
Right, exactly. And obviously pain.
Right.
And the pain is described, and you can, I don't know what adjectives you hear, but I feel like I've heard them all, like electric, shock-like, stinging, stabbing, burning, zapping. Someone said whizzing, and I didn't know what that meant, but whizzing.
Like zapping. Whizzing and zapping.
When I was a kid, people would say I have to take a whiz. Right. But obviously it didn't mean. So anyway, so it's interesting how people will describe their pain. Right. So that is the neuropathy part of it, which is why it's called small fiber neuropathy. People should know that it is not a large fiber neuropathy, which means that EMGs and nerve conduction studies are normal, right? So it doesn't pick up small fibers. Right. So the gold standard, although I don't know if it's called the gold standard because I think there's still some controversy on the skin biopsy, but we do the skin biopsy to confirm it. It looks at epidermal nerve density, and
sweat fibers.
And the sweat fibers as well. And so yeah, there's two components to the pathology report. And so then that's where, and if it's, of lower concentration, it's thought to be consistent with small fiber neuropathy. I see a lot of young people, like kids, so there aren't normative values for young people, but I extrapolate. And frankly, it goes back to clinical suspicion. I always feel like if they're outside of the normative values, and there's no research to prove that kids would have a different range of values than an adult would. And it's not like I'm seeing 4-year-olds, by the way. It's like teenagers, right? And even in pediatric neurology, we just sort of look at them as just very young adults, because oftentimes, at least their neurological systems work very much the same. So, but yeah, so do the skin biopsy, and if it comes back positive, then you have small fiber neuropathy. Right. The lab that I use also checks for certain proteins like synuclein and amyloid, which can be causes of small fiber neuropathy. Right. And that's what's nice about the lab that I use. And then we grapple with what happens when it comes back with positive synuclein.
So what do you
right.
do then? Right.
So
before we go into that. I think it's important to emphasize that a negative skin biopsy does not rule out small fiber neuropathy. Correct. Because there's a large risk of sampling error.
Yes.
Right. For people not familiar with the skin biopsy, I think it's a 4-millimeter punch on your gigantic leg, right? And you do 2 or 3 of them.
Do 3,
okay,
yeah.
Usually on the lateral aspect. So if you think about 4 millimeters times 3, 1.2 centimeters, compared to whatever length the leg is, as the risk of sampling error is actually quite huge.
Very, very huge.
Right.
Huge. That is true. I mean, you take 3 to try to, decrease the risk of sampling error, of course, but it still doesn't decrease it enough where it isn't a large concern for sure. So it does not rule out small fiber neuropathy. And again, it comes back to clinical suspicion. And so if you have a lot of these kinds of symptoms and your electrodiagnostics are normal, and you have other septad diagnoses, right? Then there's a good chance that you have a level of small fiber neuropathy. And sometimes there's a purely autonomic presentation, frankly. Right. You don't have to have the neuropathic type of symptoms. It could just be autonomic. So, in fact, a very common pattern, speaking of sweat function, a very common pattern we see with small fiber neuropathy is excessive sweating of like proximally, so of the core, of the trunk, and then decreased sweating of the distal portion, so our hands and our feet. And because of vasomotor dysregulation, you can see changes of temperature and skin color of the hands and the feet, which is often associated with dysautonomia. But it's really related to the small fibers that innervate basically the vessels. And so there's pseudomotor dysregulation, there's vasomotor dysregulation. You can see hair loss, trophic changes of the nails and the skin. Right. This is all about small fiber neuropathy and its autonomic component. And I think that's what's so interesting, and obviously not only resting tachycardia, but orthostatic intolerance, orthostatic hypotension, and then a bunch of the others that I already mentioned.
So let me ask a heretical question.
Heretical?
Heresy.
Oh my gosh. You're going to get us in trouble.
No. What in our patient population, in a population of patients with obvious, clear, no questions, unequivocal autonomic nervous system dysfunction, right? What do we gain by doing the skin biopsy? How does it alter treatment and management?
Yeah.
And I ask that I asked that realizing we always like to get concrete diagnoses, and I realize there's a reason to get it for insurance purposes and all that garbage. But from a strictly management perspective, how does it change anything? And
It doesn't.
Because I've actually I almost don't do them anymore. I mean,
Yeah.
what I learned in the first 5 or 6 years is literally 98% of patients with POTS or dysautonomia and all of its disguises had positive skin biopsies, and it's not like that changed whether I used a beta blocker for their tachycardia, and I still had to deal with their pain whether I'd proven it was small fiber or not. I still had the issue.
I mean, I hear what you're saying, and it really doesn't change management. And I think you and I are both at the point where we just take a good history and we know it's small fiber neuropathy.
Right.
And I'm going to treat it as such, regardless of the skin biopsy, right? But, I will say, though, there's a lot of etiologies of small fiber neuropathy, and it could take a bit of a workup to do. And so sometimes I don't feel right sort of proceeding with that kind of workup until I've, at least confirmed for it, sometimes the patient, but also for their insurance, that you really do have small fiber neuropathy, and it's worth doing these tests. So as I already said, EMG is going to be normal. So if I do a skin biopsy first and it shows small fiber neuropathy, then I don't even bother ordering an EMG or doing the EMG. But what are the other causes? So autoimmune, like things like Sjogren's and lupus and sarcoid, right? These are all, you can look at blood tests and you can order tests to sort of see these. Glucose intolerance and diabetes. Right. Certainly there's vitamin toxicity, vitamin deficiencies, chemotherapeutic agents, like lots of meds can do it. Some, fluoroquinolones actually causes small fiber neuropathy. So, amyloid, so these are things that you can test for. And, sometimes I feel like a patient just thinks I'm just ordering a bunch of labs for the sake of ordering labs. And, so to prove that they have small fiber neuropathy is why I do the skin biopsy. And when they see the positive result from the lab, then they understand the workup that I'm trying to do.
So I guess excuse me, my approach is a little different. I run almost all of those tests anyhow. Okay. As an initial workup, all of those autoimmune panels, the vitamin panels, I don't run routinely arsenic or mercury. That's true.
Right.
But I don't think that when a patient walks in with a septad that they have arsenic or mercury poisoning. I just don't think it's what's going on. Amyloid is a good point. I guess my question is, well, what do I do about it? What do you do when you get back a synuclein or an amyloid on your patient?
So it's a really good question.
I'm filled with good questions.
So, all right, some background. So, in neurology, and I'm really simplifying this just for the sake of our audience, but a lot of neurodegenerative disorders, a lot of those scary diagnoses that patients are often afraid of, there are sort of these two very gross categories. So like synucleinopathies and tauopathies, right? So the most common tauopathy is Alzheimer's disease, but there are many others. And the most common synucleinopathy is Parkinson's disease, but there are many others. What's interesting about the synucleinopathies and what's interesting about how often I get a positive synuclein on a skin biopsy is that the synucleinopathies all have an autonomic component. Right. So it's interesting that I think that there's an overlap with our patients and their diagnoses and presentation and symptoms with the synucleinopathies. And so patients, of course, get a positive synuclein, and then they immediately go to Google, and then they always think they have Parkinson's, and they never have Parkinson's. And as far as I know, and as the literature will tell us, they are not at risk of developing Parkinson's. What we do know, and what the few studies that have been done thus far have said, is that the positive synuclein seems to be associated with a more moderate to severe phenotype of POTS, right? Which just means that your dysautonomia is a little bit worse than someone who does not have synuclein. But we also know that deposition of synuclein on those small fibers causes a small fiber neuropathy, and is what exactly involves the autonomic nervous system. So, which is why we think there's a worsening of the autonomic component of small fiber neuropathy. So that's how I describe it. Synuclein is obviously it's this abnormally folded protein, and it shouldn't accumulate, but it does. And we think what happens is over time we lose our endogenous means of unfolding it and refolding it. Exactly, or removing it or cleaning it up, as you say. And I do think that just comes along with the chronicity of our patients, right? They've been sick for years. They've had a lot of inflammatory response, a lot of aberrant immune response. And I think along the way, that's what's disrupted our natural ability to clean up these abnormally folded proteins. Synuclein just being one of them, by the way, right? So
which is
amyloid is another.
Similar to aging.
Absolutely. Aging is an abnormally misfolded protein accumulation disease.
Right.
Absolutely. And that's what we, and I think we've said that before,
Right.
but
We're leading up to that episode.
I know. we borrow from the longevity world.
Exactly.
We do all the time. I mean, all the time.
Yep.
Yeah. So, and it's for that reason, and I think the longevity world people need to sort of join our fight.
Yep.
But because they know a whole lot more than we do, because that's what they're focused in on.
Right.
Have you been following some of those longevity people?
I do.
Do you follow like Brian Johnson, his blueprint
I read some
plan?
of it. Yeah.
Yeah, it's just fascinating to me.
Yeah.
Anyway.
No, I follow a lot of. There's I mean, this is totally off topic, although it will be on topic eventually.
Yeah.
There's a great site called Rapamycin News. Rapamycin News, I think it's called.
Mm-hmm. Oh, I never heard of
and
it.
it's great. There's so much information and so many links to send you out into the world.
Wow.
Yeah, I'll send you the link.
Yeah, I would love to see that.
Great.
Yeah.
Which we have to talk about in one of these episodes.
I know, we really do.
Yeah.
Because then it leads us into the regenerative medicine that we do regularly for patients. So, but yes, so that synuclein just being one of those proteins, and you're absolutely right. That's what aging is about. So synuclein, so that's how I describe synuclein when it comes back positive on the skin biopsy, because it does worry patients. And sometimes I sort of grapple with the idea, like, am I just ordering this, and am I just sort of, in some ways, like not doing justice to the patient because I'm just giving them more things to worry about?
Yeah, well,
but
I
like
data.
data.
When I said heresy, it's because we're trained. Physicians are trained to try to get objective documentation of each diagnosis, if there is an ability to do that. So there is for small fibers. So
Correct.
Why wouldn't every single patient get skin biopsied?
Right.
Which is what I used to do. The first visit, basically, they walked out with 3 holes or 2 holes in their leg and a hole in their arm and a bunch of kits. So,
and you stopped doing that's not.
I've pretty much stopped doing it.
Well, you do more telemedicine now too. So
but even when I'm meeting now I'm trying to make. I mean, not trying. I'm insisting, except for bedbound patients, an in-person visit, and I'm not doing it. And I meant what I said before. The main reason to do it now, in my mind, is to have a paper diagnosis to throw in the insurance company's face if we try to fight the battle, which we lose, to get IVIG, which is well proven to treat this.
Correct.
So that's my rationale.
Yeah, I agree. I think because we work in such a world of uncertainty and of controversy, I think that's my bigger point. Our world is so wrought with just people second guessing what we say and do with patients, and so much controversy, that if I can have an objective piece of information to prove a diagnosis for this patient, and if that will serve them well in another doctor's visit, then I think that's why I do it. Right.
No, that makes sense. I guess I've become
cynical.
Increasingly cynical and frustrated by the reactions of other physicians, and sort of throw up my arms and say, well, okay, so I can prove it's small fibro, but they still don't believe me, or they still won't help me prescribe the LDN for that patient, or whatever else we're doing, or help with the IVIG if the patient's out of state and we need their co-op. So plus it's more money. It's usually out of pocket, and I'm already spending so much of the patient's money on my fees and on all the labs and special kits and everything. So that was my logic.
No, I think your logic is sound.
I won't go to jail.
You won't go to jail over it. But yeah, so I still very, very often recommend the skin biopsy for those reasons, though. So and you don't have to order the synuclein. I mean, there's another lab that you can use that doesn't do the synuclein automatically, and you can actually request not to do the synuclein. Like I said, I find it to be a little bit more, evidence that we need to be more aggressive with regards to treatment, because what we don't want, of course, is further accumulation of the synuclein. So
let's talk about management.
Okay, management.
You're first.
I'm first.
All right, I'll go first. Okay, so LDN.
Yes.
Low dose naltrexone. I had a bunch of new patients this week. That's every single patient I prescribe it to, unless they told me they've had it. And if they tell me they've had it and it didn't work, there's 2 key questions. What dose 3? Did you taper up? What dose did you take? And how long did you give it? Okay.
Right.
I want to emphasize that to everybody. I was going to say it in a bad way, but I'll say it that way. Don't tell me you took a medicine and it didn't work, because I'm warning you now. I'm going to really grill you what you mean by that, because so many patients or their physicians say, oh, it didn't work. Stop it after 2 days. Okay. And they gave them 25 milligrams of metoprolol twice a day and their blood pressure dropped. Well, duh. Well, what do you expect? Anyhow, sorry for the editorial.
No, it's good.
So
It's
LDN
true.
is really crucial. It can really help with the pain. It's not as good for small fiber neuropathy pain as it is for fibromyalgia-like pain or other muscular pain and back pain and stuff. But it can help, and it's zero risk. And
Yeah, I completely agree. And
Right.
speaking of fibromyalgia, by the way, studies have shown that at least half those patients have small fiber neuropathy. So remember there were days when the fibromyalgia was called a wastebasket diagnosis,
Right.
and no one believed in it. It was just given to women and all that stuff,
Sure.
right? So clearly something organic and physiologic is going on because half of them have small fiber
Yeah.
neuropathy on skin biopsy.
Right.
So anyway, wanted to throw that in there. That I think that, and it'll outlive me, but past my lifetime, they're going to prove all these diagnoses were real, and everything everything that we know to be true is true, and they're going to come up with lots of evidence to prove it, and everything's going to be evidence based, and I'll be 6 feet under.
I'll be dust
with the maggots.
Evidence-based medicine. Don't get me started on that.
But LDN is certainly my favorite and my go-to for small fiber neuropathy. It is so effective. Small fiber neuropathy for all reasons, right? So like, obviously we call it idiopathic because we don't always know, but
Right.
we know it's post-viral, it's post-exposure. For a long time, I worked with a lot of patients who had adverse response to gadolinium. Did the gadolinium deposition disorder.
Right.
And I still do. I just don't do the chelation any longer like I used to in the past. But all of those patients developed the small fiber neuropathy, and they really responded to low-dose naltrexone. So I just know that it's very effective at sort of at least masking the damage that was done to the small fibers so that the symptoms are minimized.
So the other reason I think LDN works is that it modulates the immune system, and in most of our patients, SFN is probably an autoimmune disease.
Mm-hmm.
So in the same way LDN can help other autoimmune autoantibody diseases, it can help small fiber neuropathy pain, actually not just as a pain drug, but as a altering the cause drug.
Right. And the other thing about the small fibers, of course, is the mast cells. They sit, right at the edge of those small fibers. And so when you have mast cell activation, stabilizing the mast cells can also help minimize the symptoms of small fiber neuropathy.
Right.
So I do a lot of mast cell management, which low-dose naltrexone does that as well.
Exactly.
But I also find use out of cromolyn and ketotifen and our usual mast cell kinds of drugs. I don't find much use out of the antihistamines when it comes to small fiber neuropathy symptoms.
I agree.
So I tend to stay away from those. But, even just beyond other pharmacologics, which we can get to, but I actually find great use out of things like turmeric. In fact, I've been compounding curcumin at 500 milligrams twice a day for patients, and it really does seem to help.
Compounding as opposed to buying it?
Yeah.
Why?
It seems more pure and more concentrated. I just, I've become a little bit skeptical about a lot of the supplements on the shelves over time because...
Well, I am too. I would be concerned unless this is all bogus, in the bioavailability of compounded compared to some of the commercially available supplement products which claim to have higher absorption because they're nano or they have other ingredients to promote it.
Right. So, you just put it with pepper. You compound it with pepper.
Yeah. Okay.
Yeah. Or you can put it in an oil-based.
Yeah.
So I've found just curcumin to be very helpful for a lot of the symptoms. It's, powerfully antioxidant and anti-inflammatory, of course.
I agree.
And then just, other things, things like, even magnesium has been helpful for some of my patients at higher dosages, but that unfortunately the diarrhea component of magnesium gets in the way. But then a lot of mitochondrial support has also been helpful.
Yeah, that makes sense.
Yeah, and then managing glucose levels. Glucose intolerance has long been associated with small fiber neuropathy. Diabetes has long been associated with small fiber neuropathy, though large fibers are very much involved with diabetic neuropathy. But there's a small fiber involvement as well. So I even find that I will sometimes give them a continuous glucose monitor, and so we'll check sort of how their glucose sits, and if they have dips and ebbs and flows and
peaks and valleys.
Right. I'll put them on metformin, which has been very helpful actually.
Helpful for the peaks and valleys or for the pain? No, I'm serious.
Well, for the peaks and valleys,
Yeah.
but that seems to help the
It
pain.
does. Okay.
So there's some glycosylation
Right.
component, I think, to the pain, because the pain is not chronic and consistent for the most part. It does tend to go wax and wane, to
Right.
go up and down, and I don't know why, and I'm not pretending that I know absolutely it's because of the glucose levels, but there's, if I can correlate it at all, I will. If they clearly have ups and downs on there trending with the continuous glucose monitoring, then I will give them metformin and it'll even it out and balance it out, and they do seem to actually feel better on it. Metformin is also mitoprotective, so who knows?
And also immunomodulating.
And it's immunomodulator, right?
It
exactly.
may be
So who
working
knows what
like
it's working
LDN
on?
in some ways.
Right, totally. But I do a lot of IVIG for small fiber neuropathy when I can get it approved, which can sometimes be really hard.
Well, let's spend a minute on that, okay? So at this point, that is probably the only well-proven, well-documented, literature-supported,
Yes.
peer-reviewed, blah, 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 way to treat small fiber neuropathy.
Mm-hmm.
The problem, as usual, is that the FDA has not made that an indication for IVIG, which lets the insurance companies deny it. But I want to emphasize that if it can get approved, it can be dramatically helpful, and there's paper after paper to prove that.
I agree, because I see it. We see it,
Yeah.
When I have patients who are on IVIG, their small fiber neuropathy symptoms all improve, including the autonomic symptoms. So it's not just the pain.
Right. Well,
Yeah.
it's because it's treating an autoimmune disease.
Right. So what I'll do sometimes is that I'll do like a very extensive autoimmune workup, trying to find a diagnosis that I could appropriately apply to this patient so that I could appropriately use for the IVIG prescription. Not always successful, in finding that diagnosis A, and if I do, not always successful in getting it approved, but does seem to, at least it seems to increase the chance of the approval. But IVIG can be very, very helpful.
So in your experience with IVIG, have you seen it continue to be helpful when you stop giving it? Or is it the more common pattern of improvement and then decrease before the next?
There's definitely a sustained response.
Sustained response.
Yeah.
Okay. And have you seen that also with plasmapheresis?
Oh, 100%. Yeah. Plasmapheresis is my new favorite treatment.
Yeah, I know. That's why I brought it up.
I mean, it's sort of the way I describe it to patients. It's like, these patients have been so sick for so long that, stuff has just been built up in there, and things left as, marginalized in the lumen of the vessels. And so things are like stuck to the walls. Yep. And unless I use a roto-rooter, I don't know how to get it out, right? But the plasmapheresis, because of the pressure involved in basically the exchange of the plasma,
Right.
it really does clean it out. And that, because what seems to happen is some of the medications that we regularly use has a greater effect, and I can't explain it any other way than that, is that I've removed whatever was interfering in the efficacy of
Right.
the other treatments that I'd already tried.
Well, in a sense, you've lowered the burden of the disease, so the drugs
Right.
work better.
That's true. Exactly. That's sort of another way of looking at it. So, the problem, of course, it's expensive. It's not covered by insurance at all. I mean, that's not even a fight that I can even get into. IVIG, I regularly fight insurance companies over. But plasmapheresis is hard. There's such specific indications for it that it's really hard to sort of fit a square peg into a round hole.
And you get the same durable responses?
Oh, yes.
So you can do the IVIG for 6 months, stop, and the patient remains better.
Mm-hmm.
And obviously with plasmapheresis after 6 or so, stay better.
Mm-hmm.
Okay.
And then I'll give IVIG at the end of the plasmapheresis protocol.
Right.
So they'll get a little IVIG just to sort of boost their immune system, because obviously we remove some of the antibodies. But they do really well. And like I said, then the medications work better. I've also found that, so it is interesting to me, the longer I do this, the more I realize, why I think some medications don't work as well as we hope. It's because there are things that are in its way. So plasmapheresis is sort of one way of sort of removing, as you say, the burden of disease, which is an appropriate way, a completely incredible way of putting it. But also, again, we're going off topic, but all those anatomical diagnoses that our hypermobile patients seem to get, I've also found that, I'm trying to treat these symptoms, and they get no response to these medications. When they have the surgeries, then all of a sudden those medications are magical.
Right.
And I think it's because we've allowed proper blood flow again, more homeostasis, more alignment where things are more receptive to other interventions.
Well, I think we're removing surgically an enormous cause of all the problems.
Right.
Cause of mast cell degranulation, independent cause of dysautonomia, meaning brainstem compression,
Exactly.
separate from the initial autoimmune. So it's a amazing.
Yeah, that's exactly
Right.
right. Because we're not curing mast cell activation syndrome by fusing your spine, right?
Although it
So
seems that way at times,
it
I have
it
to
does
say.
at times seem that way. I completely agree
Yeah,
with that.
it's,
So we're not curing it though. So it still sort of exists. But all of a sudden, all the meds that we regularly use is way more effective in these patients because they've had, as you know, like the burden of the disease partially addressed. So, so same thing with plasmapheresis. You know, once you get that cleared, then everything just sort of seems to have a place to go when you give it.
So, going back to the more easily accessible medications, which is not to say, I mean, I totally agree with you. I have more difficulty than you since I'm not, quote, a neurologist to get insurance to agree to the IVIG, so it's very frustrating. So in terms of other medications, NSAIDs,
Yes.
ibuprofen, I particularly like Celebrex, less gastritis, mast cell activity, and just seems to work better.
Yeah.
I find. I can't explain exactly why, but it does. I've tried gabapentin.
It never works.
Never works. I hate Lyrica. I don't think it actually helps much. I think you use Lyrica more than me.
I do.
And then there's the tricyclics like nortriptyline.
I like nortriptyline a lot.
Those can be good.
Yeah, I've been using indomethacin more and more lately, and I know you mentioned the gastritis. It can rip up your stomach for sure, but it's very effective. Very effective.
I should try that. I have not done that.
Yeah.
Yeah. I guess the problem with the oral meds is they have potentially lots of different side effects.
Lots of different side effects.
And they're not uniformly effective by any means.
No, I mean, they're not. Especially a lot of these, we're speaking mostly about treating the pain of small fiber neuropathy.
Right.
I don't find any of those to be very effective for the autonomic parts of small fiber neuropathy.
Right.
So I think
No,
that's...
I'm just talking about pain management.
Yeah, pain.
Yeah.
So yeah, I mean, and I've had patients try, the CBD and the THC classes, which we've said before, we're not experts on. And so I tend not to guide them on that or give any kind of advice because I don't feel like I know enough yet.
Right.
Although I wish I did, because people ask all the time. I'm sure they ask you.
Yeah, sure. Of course. All the time.
But, and then, people are going for, when it's really severe, they're getting great relief out of ketamine.
Yeah, ketamine's the big new guy in the block.
Yeah.
And it works.
It does work, for sure. It does work. And, the blocks, like the stellate ganglion blocks and the sphenopalatine blocks can be helpful as well. But I think we also mentioned in our pain conversation, the CGRP class of meds are very effective. I think that they're one of
peripheral neuropathy?
For peripheral neuropathy, both small and large fibers. And again, I know their indication is for migraines because that's what it was studied in and that's why it was designed. And so that's what insurance will cover it for. But the large percentage of our patients have at least headaches, if not migraines. Right. So, so you call it a migraine, tomato. Right. And, and I just give them CGRP and they love them. They love them. And, I give them the abortives, of course, which is Nurtec, Ubrelvy, and Qulipta.
Yeah, I've used Nurtec. I haven't seen that, but I will definitely look at that more.
Yeah, try some of the others. I mean, Ubrelvy has actually been my new favorite lately of the abortives. And I always say that if we find that you get a lot of effect out of the abortives, then I'll just put you on a preventative, So
problem is getting approval, especially not as a neurologist.
Right. But I think that, to be honest, I think a lot of primary cares are sort of now using the CGRP class of meds.
Yeah, I think they usually get a neurology consult to back them up. But I will try them more. I mean,
just say you consulted with me.
Okay.
Our podcasts are our consults.
Right, exactly. There's another med I was going to say. CGRP. Damn.
Yeah.
It'll come to me.
Yeah. So speaking of pregabalin, the Lyrica, I do like it. I really like the gabapentin and the Lyrica together. There's a synergistic effect. And it does seem that when patients are on gabapentin, they say it doesn't work. I give them a small dose of Lyrica, and then all of a sudden their symptoms are better. So I do think there's a synergistic effect that I think is worth trying. And then, of course, the peptides, BPC 157.
Yeah, that's what I wanted to get to next.
Yeah.
So just to explain to people, I mean, the reason I don't like Lyrica is that I find it really increases brain fog, and it's very difficult to taper off for most patients. So I just don't use it. Or almost never use it. But maybe that's stupid and I should try what you're saying.
You should. Yeah. Try like a low dose, as I said, with the gabapentin.
Right.
And you can go high in the gabapentin, but a low dose is really good. And I do like the tricyclic antidepressants. I do a lot of nortriptyline for sure.
Do you use tramadol much when the pain is intractable?
I do use tramadol.
Yeah, me too.
Yeah, I do. I like tramadol. I know lots of people don't like it.
No, I like it. It's actually for a large group of my patients, it's the best pain med.
Yes, and then I also go to benzodiazepines.
Yeah, well, of course. You know how I feel about them.
Pain control. Benzodiazepines manufacturers should sponsor this podcast because we talk about them all the time.
So, I'm going to really go on a diversion. You ready?
Yeah.
Politics, folks. Political warning. Did you get an email yesterday about the new DEA rules?
Oh, I did. It's insane.
I'm really going crazy about this.
It's insane.
So the DEA, Drug Enforcement Agency, that gives us our license to prescribe controlled drugs. Okay. And neither of us, or rarely, if ever, prescribe a narcotic. So controlled drugs is testosterone, benzos, tramadol, I think is, that's it, right? That we use,
I believe
that you and
that's
I
it.
would use. Okay?
Yeah.
And they are mainstays of treatment for us. The DEA is requiring an 8-hour course in order to renew our license.
And I just did one.
It's
for another
unbelievable.
state.
And I'm seriously thinking of refusing and just not renewing my DEA. I'm not spending 8 hours of my time to do this.
I don't blame you.
But on the other hand, I have so many people I write these prescriptions all day long.
No, I know I think that if people understood the burden on doctors to just keep licensing up. So I have licenses in several states, and every state has their own requirements, and I can't use the same module for
Right.
2 states. They have their own modules that they want me to do on the same topic.
Right. Actually, this DEA requirement came in the same day as my renewal for my New York State license, which costs like an insane amount of money.
They're $1,000.
And I'm thinking, why am I doing this?
It's so
why should I renew this?
It's so ridiculous. I know. I'm dropping some more states.
Yeah. Anyhow.
That's a whole
Sorry
other
for the
thing.
politics.
The other thing, topical formulations can be very helpful.
Yeah.
So, I have a couple of recipes where like it's a combination of like ketamine and ibuprofen and nortriptyline,
Right.
that are compounded into a cream base, like a lipoderm base. And, if their feet are particularly painful, so if it's something more like local where they can slather it on and opposed to like slathering their whole bodies, I will definitely prescribe one of those compounded topical formulations because they can be very effective. There's a really good absorptive profile. And so it really does seem to get at the small fibers enough. Obviously the small fibers are up at the very surface, which is why you can do skin biopsies and find them.
Right.
So I find those topical formulations when it's a local area, like their feet, which is the most common area that I hear about. But I find those to be very effective as well.
So another point to make, I think, is, and we talk about this all the time, about how everything is interconnected here, is these patients all have dysautonomia, and they almost all have POTS and hypoperfusion syndromes. And it's critical to fix that, if possible, because that perfusion of blood is going down to the leg to
Right.
those nerves. And if they don't get properly perfused, they're just going to get sicker and sicker.
That's right. That's so true.
Yeah.
And then you think about, speaking about dysautonomia now specifically, but again, there is an association with small fiber neuropathy, the coat hanger pain, which is thought
Right.
to be related to abnormal distribution of blood flow because of the vasomotor dysregulation. That applies to everywhere else in the body.
Yeah, exactly.
Right? So, you might feel some pain between the scapula because of abnormal distribution of blood flow. But again, if you think about all the different organs that need to be perfused, and if you don't have appropriate distribution and the caliber of the vessels don't constrict and dilate appropriately to accommodate changes of blood flow because of changes of position or changes of hormonal status or change in the barometric pressure. There's a million reasons why homeostasis is supposed to work and it doesn't with dysautonomia. Then you can obviously have poor perfusion of a lot of different parts of the body. And certainly our chronically ill patients don't need that. And I always talk about the inflammatory barrier that exists, right? Just because of their histories, that makes it even harder for the blood to perfuse into the tissue. So not only do you have abnormal distribution of blood so that not enough blood is in one area and there's too much blood in another area, but there's an inflammatory barrier that needs force for that blood to penetrate through to get into the tissue. And so that requires a lot. That's why I like HBOT so much, because it gives that force. So it allows for better perfusion of tissue, specifically of the brain, is what I'm always thinking about.
Yeah.
Which brain fog we're going to talk about next.
Okay. Peptides.
Peptides. Yes, we love peptides.
Yes, we do.
The peptide pharmacy should also sponsor us.
Peptides are great.
I know. I love, so for this purpose, BPC 157 has been really effective. It comes as
injectable.
In the injectable. I was going to say it comes as an oral, but I haven't found that to be effective at all. I like the injectable a lot. It does come as a cream, so sometimes I'll order that too. But I really like the injectable, and I think it's been very helpful for patients.
Right. Easy to give, 0 side effects, not insanely expensive.
Yeah.
not FDA approved, no insurance coverage, can't ship everywhere. California will not allow it into the state for injection. I can't get off my politics this morning. It's because I read some articles before I got here.
Well, yeah. So do you know cerebrolysin?
Yeah.
Okay. One of my favorite peptides, frankly. You can only source it outside of the country now, and it was held up in customs and has now been slated for destruction by the government.
It's just unbelievable.
I know.
Anyhow, so BPC is great.
Yes.
And we use it for other things. I use it in all my SIBO patients for treatment of small intestinal bacterial overgrowth. KPV, ARA 290.
Love them. For neuropathy, those are the best ones. Yeah.
Right. And there's a third, TB4, thymosin beta 4.
Yeah, because we can't do TA1 anymore.
Right, and we can't do TA1. Don't get me started again. So they're all great.
They've taken all our tools
Pretty much
away.
no side effects.
None. The only side effect that I've ever heard and seen is with the injection. Sometimes when there's severe mast cell activity, the injection itself, so the actual physical act of injecting the needle through the
I have
skin,
one patient this
can
week
sometimes
who had
cause a
that.
mast cell, and they get a wheal, and it's very painful,
Right.
and it gets red. And
Which brings me to a question I asked you offline, off Patreon texting, which I do all the time, all week. Thank you for always answering. So I have a patient who had a huge reaction like that, which is why I asked you about giving an IV. So I'm going to give it to her IV and see what happens.
I think that's great.
And I did some research, and there's no reason. It's formulated without anything that would make it not usable for IV. In other words,
Right.
it's injectable, so it should work.
They're just amino acids.
So I'll let you know.
Yeah,
Stay
let me know how
tuned.
that goes.
Stay
No,
tuned.
I'm actually very curious because I would like to do it
Yeah.
for myself IV, frankly. I'm trying to do all kinds of different weird IVs for
Right.
my own
Right.
purposes. I'm actually doing IV quercetin. Did I tell you that?
Yeah, you did tell me
Yeah,
that. Yeah.
very excited over that.
So peptides are great.
yeah.
Right.
Peptides are great. Love peptides. And there are so many peptides. And to be completely transparent, I don't know enough about all of them that are out there. I'm sure that we would find benefit to many others that
Oh, yeah, for sure.
I like to, as I know you are, and that's why I like working with you, we like to be confident in what we're recommending to our patients and what we're giving our patients. And it just does take time to research each and every peptide that comes out from the pharmacies and what its purposes are, what we can use it for, its safety profile, of course, its toxicity profile. So we like to vet what we give our patients.
Well, and
it
it's
takes time.
And it's not so easy because it's way, way out of mainstream
Right. There isn't
medicine.
enough literature.
So the only, other than trying to read, is going to the few meetings that might be focused on it.
Right.
those are
And
not-
asking questions. Yeah.
and those are not, quote, academic meetings,
They're right.
but they're excellent, and you really can learn a lot.
Yeah, I agree. So that's one of my goals for 2023, even though we're already into June and I haven't done it yet, which is that I really want to take the time to learn about some of the other peptides that I have not been using as regularly because I'm just so impressed with the response we get with the peptides.
Right, I agree.
So that's exciting. Yeah. So we'll
definitely.
get there. But yeah, so all these things are very helpful for small fiber neuropathy and many of its symptoms that it manifests with.
Okay.
Do you have any other questions, Dr. Kaufman?
Other questions? No, I mean, we can get into things like rapamycin, exosome, stem cells, but I think we should probably wait on those.
Yeah, I think we need to do a whole regenerative medicine podcast.
Right. But I will say, I hate to have a negative note here, that notwithstanding everything we've been saying, I find the management of the pain of peripheral neuropathy very difficult.
Yeah.
And I don't feel that I'm all that successful with patients, and it's very frustrating.
Neuropathy is notoriously difficult to
Right.
treat. And that's why it's important to understand the reasons behind it, because maybe then it gives you a different path of treatment, which is
Right.
why I do the whole workup to sort of see if I can identify. And I will say that 50% of the time, or probably more, I don't find.
Right. I should add, I would be really upset if I didn't remember to add that as part of the workup, you need to think about infection. Okay, I know that's a little bit of a broken record for me, but viral reactivation, EBV, those viruses can cause peripheral neuropathy. Tick-borne infections, Lyme disease, Bartonella, probably Babesia, absolutely can cause neuropathy. So they need to be considered.
And do you treat as infection then? Antivirals, antibacterial?
If I demonstrate it, yeah.
Yeah. Okay. And and you have found that will improve the
Yes.
small fiber
Yeah.
neuropathy pain?
Right.
Interesting.
And if in some patients where I haven't looked, if we're not getting anywhere, I will reopen that discussion and conversation. You and I share a patient, which I've just said to him, we need to do the full tick-borne disease workup because we don't have a good answer for this, and
Right.
you're not getting better.
Well, we know COVID caused a lot of small
And
fiber
COVID,
neuropathy.
yeah,
There was that big
perfect.
study out in
Right.
MGH
Right.
that showed that a great percentage of patients who had COVID developed small fiber neuropathy, especially when they were in the long COVID category.
Right.
So that's really interesting in terms of the
Yeah,
infection
yeah.
component of it. Yeah. Okay.
So I think this is a topic we'll probably revisit as we discuss
can't
other
not.
interventions, because it's just so
Yeah, because
common.
I think what I like about how we practice is that we're always looking for ways to help the patient.
Right.
And very often that leads us to something that, wow, that worked. That's great. And then we share it with each other, you know, and then we can share it with our subscribers as well.
Right.
So then they can share it with their doctors.
Well, it's a very important point. So I made my little comment before about evidence-based medicine. Evidence-based medicine is great. I mean, I don't want to sound like a total idiot here. It's really important. Guidelines are important. The problem is in the patients we treat and the pathologies we deal with every day, there is no evidence-based medicine or guidelines. So does that mean we should just close the doors and not take care of our patients? Of course not.
Of course not.
And so what you and I are dependent on, and others in our masterminds, listserv, et cetera, are N of one anecdotal information. So somebody says, I tried this and it helped. Like there was, I don't know if you saw this thread on masterminds recently about nicotine patches.
Oh, yes.
I mean, right. So
Yeah,
are
no.
you guys crazy? But no, we're not
Oh my
crazy.
God, neurologists
so
have used
interesting.
nicotine patches for Parkinson's
Right.
for a long time.
And I'm not going to wait 5 years for some company to do a randomized clinical trial in order to help patients if there's something that looks like it might help. I will do a careful assessment of risk and benefit, and I'll explain that. I'll share that I don't have, the evidence base to use it, but I'll also explain why.
And that's what I was referring to before, is that we do take the time
Right.
to make sure that what we're recommending and how we're treating a patient is at the very least safe, has at least a decent chance of having a benefit, right? We take the time to read and know what we're doing, and so we can answer even any questions about it. And that just takes time. And so I think, and that's what I meant, is that I like to vet any kind of treatment plan, any kind of treatment protocol that I recommend. And it just takes some time. But when I do recommend it, I have a level of confidence that at least I know the patient is safe. I mean, of course, I always say anybody could be allergic to anything, right? So I always say you might have an adverse effect because, again, with mast cell patients, you never know what they're going to be sensitive to. But I always start at a low dose, of course. So I take great precautions to sort of keep them safe. So yeah, I agree with you completely. I cannot wait for a randomized control trial, which can take years.
To me,
because the patient sitting in front of me I had a patient the other day just wants to be able to walk her dog. Yeah. I mean, simple things in life these patients just want to do. Simple things.
It's a cruelty of mainstream medicine.
Yeah.
And the final example is the whole long COVID experience that's evolving, where the NIH and their recover trials, they're just taking forever.
I know.
And meanwhile, literally millions of patients.
God.
I mean, I have had so many long COVID patients recently. It's just overwhelming.
I completely agree. Completely. I've had so many long COVID patients as well, and very concerning with regards to their neurological presentations. And I worry about the future.
Yeah.
I'm like Chicken Little. I don't want to be Chicken Little.
All right. Somehow we got a little negative at the end here.
Yeah, we need a positive note.
All right. Let's wrap this up.
Lots of treatment options for small fiber neuropathy. So if one doesn't work, try another. I think that you'll find success with one or two or a combination of some of the things that we mentioned, which has been at least my experience for sure.
Yep.
That there is you can get some relief,
Well,
and
it's
that's
true
important.
with so much of what we do.
Right.
A lot of it is trial and error. You try something, give it the right kind of trial in terms of dosage and time, et cetera. Doesn't work. That doesn't mean nothing works. You go to the next thing.
Exactly. This was a good conversation.
Yeah. Okay.
Thanks,
Thank you very
David.
much. Thank you.
See you next time. Bye.